This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Today we're fortunate enough to listen to Amy's plans for the future. So I think on the road to world domination, her first stop will be antimicrobial resistance in urinary tract infections in dogs and cats. Amy was a veterinary graduate from the University of Melbourne who surprised us all by coming back and surprised us even further by being interested in actual hands-on laboratory bacteriology. So Amy, rather than spoil any more of your talk and steal any more of your thunder, I will hand over to you.
Thanks, James. And thanks everyone for coming to my confirmation seminar. So as James mentioned, my topic for my PhD is antimicrobial resistance in urinary tract infections, and primarily in dogs and cats. So James is one of my supervisors, and Laura is also my supervisor. In this talk, I will give a brief introduction on antimicrobial resistance. In the literature review section, I will discuss some definitions, diagnosis, and treatments for urinary tract infections. I'll run through the methods involved in my intervention study and the results I have so far. And then I'll briefly talk about my future plans. So antimicrobial resistance, or AMR, is a global public health threat that massively increases healthcare costs and reduces economic output. Antimicrobials are used to in the treatment of various medical conditions where they kill or inhibit microorganisms such as bacteria, viruses, parasites, and fungi. Resistance occurs when the organisms no longer respond to the medication and the drug fails to clear the infection. Unfortunately, there have been limited new discoveries, and the development of novel antibiotics in the recent decades have been quite slow, which is why we must preserve what we have by reducing the development of drug-resistant organisms. Antimicrobial resistance is a process that can occur naturally through spontaneous mutation or are passed through horizontal gene transfer between strains and even species. The inappropriate use of antimicrobials increases the likelihood of resistance developing and leads to the production of multi-drug resistant or MDR organisms. In this talk, I will be referring to antibiotics specifically, as antibiotics are relied heavily upon in veterinary medicine to treat infections and are important in maintaining animal welfare. To reduce or prevent the development of antibiotic resistance, veterinarians need to ensure that their use of antibiotics is justified and to use low-rated importance antibiotics wherever possible. Some examples of inappropriate use would be using the wrong antibiotics, prescribing antibiotics when it's not required, and inadequate dosing. So importance ratings for antibiotics have been determined by the Australian Strategic Technical Advisory Group on Antimicrobial Resistance, or ASTAG for short. The ASTAG ratings aim to provide information to inform decision-making about the registration and use of antibacterial medicines in Australia. And the advisory group includes representation from human health, animal health, food, agriculture, and environmental. These ratings will differ to international documents like from the World Health Organization and OIE, which provides broader recommendations for countries with limited resources. Wherever possible, countries should have and regularly update their own importance ratings where they take into account the local availability, use, reliance, and surveillance data of antimicrobials. This is an example of how the group at Uni Melb has used the traffic light system to illustrate the importance ratings. So we have low rated represented by green, orange for medium importance, and red for high importance. High importance would mean that the antibiotics is essential for treatment or prevention of infections in humans where there are few or no treatment alternatives for these infections. Now, moving on to urinary tract disease. Most of these definitions would be taken from the International Society of Companion Animal Infectious Diseases Guideline, or ISCAID, and this was published in 2019. And so there's two different types of infections, of urinary tract infections. Sporadic infections involve healthy animals with no underlying systemic, anatomic, neurologic, or functional problem. These cases are not recurrent and occur less than 3 times per year. And also they should not have had an infection in the last 3 months. Recurrent infections occur in the presence of an anatomic or functional abnormality, or in an animal that has a comorbidity that predisposes to persistent infection, reoccurring infection, or treatment failure. These patients have 3 or more episodes of infection in a 12-month period, and the recurrent infections can be further categorized as reinfection, relapse, and refractory. Some patients with urinary tract infections present with hematuria, pollakiuria, dysuria, stranguria, or a combination of these clinical signs. The veterinarians will usually collect a urine sample and perform an in-house urinalysis test, which includes a dipstick test, a refractometer to determine USG, urine specific gravity, and a sediment exam, which involves looking under the microscope. However, there are some limitations to these tests, and it can be unreliable in the diagnosis of urinary tract infections. Patients who are immunosuppressed or have excess systemic glucocorticoids may not display signs of inflammation even in the presence of a UTI. Urine that's too dilute or contain amorphous debris could also make it difficult to identify bacteria in the sediment exam. This is why culture and sensitivity, or CNS, is always recommended to guide treatment. This is ideally done with a sample obtained through cystocentesis, but this may not always be possible. And then the urine sample usually sent off to external diagnostic laboratory for aerobic culture. The results can take 48 hours or more to return to the clinician. In cats, the prevalence of UTIs is low, and idiopathic cystitis is a common differential diagnosis. The proportion of feline lower urinary tract disease cases that involve UTIs range from as low as 2% to 19%. Therefore, it is quite important to obtain a positive culture and susceptibility testing results before commencing antibiotics, so that antibiotics are not unnecessarily used. Often supplying some pain relief with an anti-inflammatory is sufficient while the clinician awaits the CNS results. However, if the patient is unwell, they could commence empirical treatment, ideally guided by your in-house urinalysis and local antibiograms. Local antibiograms are antibiotic susceptibility testing profiles for a specific region, geographic region, time period, and body site. Conveniently in Australia, my colleague Ree Scarborough has published a study over 6,000 urinary isolates from dogs and cats. She found that 80% of all isolated cocci were susceptible to amoxicillin, and more than 80% of rods were susceptible to trimethoprim sulfur. So both of these are, both of these are considered low-rated antibiotics according to the Aztec ratings. So both are excellent options for empirical treatment. Keep in mind this recommendation is specific to Australia. As overseas, there may be different susceptibility patterns and importance ratings, which may change the recommendations. Ideally, this type of information should be readily available for various conditions, microbiological organisms, and geographic locations, so that veterinarians can make an informed decision. So once the culture and sensitivity results have returned, the veterinarian should only change antibiotics if the bacteria is shown to be resistant to the antibiotic that they selected, and there's no clinical response. If there was good clinical response, but the in vitro results suggested otherwise, the antibiotic should not be changed. We're aiming for clinical cure in these cases. Based on the ISCAID guidelines, the recommended treatment time is 3 to 5 days of antibiotic therapy for sporadic infections. Longer courses of 7 to 14 days of treatment can be used if they're found to be urinary tract abnormalities. If there's no clinical improvement after 48 hours, there should be 48 hours of commencing appropriate antibiotic therapy. Further investigation should be carried out to identify any underlying conditions or complicating factors. Overall, there have not been many published papers establishing the recommended treatment duration for UTIs in dogs and cats. In 2012 and 2014, there was 2 randomized clinical studies that showed that short-term treatment was not inferior to longer treatment. However, these studies did not compare different lengths of treatment duration for the same drug. One of the studies by Claire compared 3 days of TMS to 10 days of cephalexin, while Westcott compared 3 days of enrofloxacin to 14 days of amoxicillin clavulanic acid. So ideally, these studies, we need some studies that have the same antibiotics, but comparing different lengths of treatment to establish the ideal treatment duration for each drug. It is also important to keep in mind that both studies only involved like uncomplicated cystitis cases and dogs specifically. There needs to be further research into the optimal treatment duration for more complicated UTIs or recurrent, now called recurrent UTIs, and for UTIs in cats. In Australia, E. coli is by far the most isolated organism from urinary tract samples. Ree found about 59% in her study. Overseas, it ranges from 30-something to 50-something%. And E. coli was also the most commonly found as a single growth, whereas Enterococcus faecalis and Streptococcus canis were most commonly found in mixed growths. For my intervention study, it's an ARC linkage program, and we collaborate with Green Cross General Practice Clinics and IDEX Laboratories, which is an external diagnostic laboratory. Veterinarians are often reluctant to perform or recommend culture sensitivity due to, well, they often cite costs as the reason why they don't do it as often as they should. Despite this test being recommended for all patients with urinary tract clinical signs. CNS is important because it helps to confirm the presence of bacteria. And if bacteria is present, to determine which antibiotic will be effective in treating the infection. Without this test, veterinarians may be prescribing antibiotics unnecessarily or inappropriately. The objectives of the study is to determine if cost is a barrier for veterinarians to carry out culture and sensitivity for urinary tract disease, and to determine if, with the availability of free culture and sensitivity testing, whether or not there's any changes to antibiotic prescribing behavior. In January, the study launched, and 10 Green Cross clinics voluntarily enrolled in this study and started submitting urinary samples to IDEXX laboratories using a special charge code that we provided. The clinics in Green Cross already use IDEXX for their diagnostic tests, so there's no interruption to their workflow, and it does not affect their turnaround time. So we pay for these CNS tests, which means that there is no cost to the client for the test to be carried out. I distributed a poster with a treatment kind of like decision-making guide to all the clinics involved, and they can also email or call if they have any questions regarding the treatment protocols. The only inclusion criteria for this study was that the patient had to have some sort of urinary clinical sign. And we will most likely close the study in December. This is just the poster that I made, and we use the traffic light system to denote which antibiotics are considered low, medium, or high importance based on the ASTAG ratings. At the top of the poster, I have provided the definitions of the different types of infections, and like a little reminder here, if possible, not to start antibiotics until the results come back, if possible. Once they've done the in-house urinalysis and they've looked under the microscope, if they see rods, TMS is the recommended treatment, and if they see cocci, amoxicillin should be their go-to. Once they've received the results from the lab, if they have not started on any antibiotics, then they can go straight to selecting their antibiotics. They should use the lowest rated antibiotics that the organism is susceptible to. So ideally one of these three. If they already started antibiotics and they have poor clinical response, then they should follow the results and again choose the lowest rated. But if they, if they are susceptible to a lower rated antibiotic than the empirical treatment they selected, then they should de-escalate. But if they're already susceptible to one of these three and they're making good progress, then they should not change the antibiotics. And here's a recommendation, some options if the patient cannot be medicated orally. There's some injectable alternatives available, which is not convenient. And also a recommendation for treatment duration. Once the samples are received at IDEXX laboratories, they plate out the samples as they normally would, but with an extra plate, which they then deliver to building 400 in Parkville. I subculture any plates with growth on them onto nutrient LB agar plates, and then preserve the bacterial colonies in glycerol broth at minus 80 degrees. As you can see on the left, sometimes I still get plates that are considered non-significant, and there's a few different looking types of colonies on there. I still subculture them anyway and preserve them. And most of these would be contamination or commensal organisms, but it'll still be interesting to do further testing on them. And on the right is a more straightforward plate with just one type of colony growing on there, so a lot more straightforward. In February, we recruited UVet, the University of Melbourne Primary Care Clinic, to join the study. And so far we have 22 samples, and Reese preserves these isolates at Werribee. And these isolates will also be included in my future projects. All right, so these are the results I've got so far. So as of some early last week, I have 159 submissions and about 100 isolates in the freezer. Just under 50% of these samples were voided samples, and just under 50% were cysto samples, and we have 4 that were unknown. 2/3 of them were from dogs and 1/3 from cats. Keep in mind these 100 isolates include the non-significant growths. So out of these 159 submissions, we've got 49% of them which came back as negative or no growth, and 11% that were considered not significant growths, and 40% positive. This is a breakdown of the isolates by species. We've got 59% E. coli, and quite a few Proteus and Staphs, and Enterococcuses. We did get 1 Candida, and this was from a diabetic cat. Or keep in mind that these percentages do not add up to 100%, as there are some samples that have more than 1 isolate, so this would be over 100% if you added them up. So 20% of these of the 69 positive cultures were mixed infections, so they had more than one isolate. In terms of drug resistances, all 5 E. coli isolates with 1 drug resistant were resistant to amoxicillin. And then we had 3 E. coli that had 2 resistances, and all of them included amoxicillin, 1 to additional amoxiclav and 2 to TMS. Multi-drug resistance, or MDR, is when they have 3 or more resistances to, 3 or more antibiotic classes. There were 15 samples with MDR growths, but 17 in total. So 2 of them were from the same sample. 4 of them were from the same 2 samples. We found that 23% of the positive samples had MDR isolates. 5 of these isolates were E. coli, 1 identified as ESBL, 5 Proteus, 5 Enterococcus, the 1 Citrobacter was also MDR, and then 1 Staph schleiferi, which was methicillin resistant. And every single one of these MDR 17 isolates, MDR isolates, were resistant to cephalexin and cefabecin or convenia. And this table shows the number of submissions by clinic. 3 clinics, number 2, 4, and 5, had clear increases in the number of submissions, whereas some clinics like number 8 stayed around the same, and we had number 7 where the number of submissions is probably too small for us to say at this point, and there was a decrease in submissions in number 6 and number 9. There was no previous data for clinic number 1, so I couldn't make a comparison. And so far we've had 0 submissions from clinic 3. I think, one of the reasons why some of these clinics have none or less submissions is that, there's been quite, some turnover of staff, and the long collection period means that they're probably new staff members who are not aware of the study. To try and overcome this, I have periodically asked the area manager to remind the clinics of the study. And so far, like, this is not included in the data, but this month I'm seeing some increases in submissions. So that's positive. There's still another 5 months, so there's still lots of time for submissions. In terms of data analysis, I received the patient histories through VetCompass in monthly batches. I have gone through January and February data so far, but I'm having difficulties with finding all the records for the patients that receive free CNS. This is because the VetCompass histories do not include the lab reference number, which is what I receive in the lab reports from IDEXX. And some vets may have forgotten to charge up the correct code that allows us to find the records that are associated with that submission. So currently we're still trying to troubleshoot this with VetCompass, but we may have to figure out a way around this. So with the histories, what I'm looking for is whether or not the antibiotics were prescribed on the day that the patient presented, which antibiotics were used and what duration were dispensed. Did the clinician change, de-escalate, or discontinue the antibiotic after receiving the results? And what other medications were given to the patient on the day, like pain relief or anything else. So far, there's not enough information yet to come to any conclusion as of now. In the future, I would also like to compare the antibiotic use for urinary tract disease cases in the time period before the study and during the study. So what's coming next? At the end of the study, there will be a questionnaire for the Green Cross and UVet veterinarians that will take approximately 5 to 10 minutes to complete. And this questionnaire contains tries to determine how the veterinarians what their thoughts were towards the free culture and sensitivity, and whether or not they thought it changed the way they prescribed antibiotics. Human ethics has been approved for this, so that's ready to go. So currently with the 100 isolates I've got from the that I've got in the freezer, they're waiting for the next step, which is Sensititre. So we're currently waiting for the Sensititre plates to arrive from the UK. Been taking a while. We've ordered 3 different plates: the urinary plate, the companion animal gram-negative plates, and the companion animal gram-positive plates. So each isolate will be run on the urinary plate and either the gram-positive or the gram-negative plate, depending on their gram staining. And the urinary plates can actually run 2 isolates on each of them. The reason why we've picked these 3 plates is because the urinary plate contains, has antibiotic wells that run to a much higher concentration than the gram plates. So I've put them in red boxes. But the gram negative and gram positive plates have antibiotic wells that run to a much lower antibiotic concentration, and it includes a much wider range of antibiotics. As you can see, there's much bigger list compared to the urinary plates. By around August, end of August, which is when we expect the plates to arrive, I should have around 130, 140 isolates. So I will resuscitate the frozen isolates onto sheep blood agar in preparation to go to Werribee for to run a Sensititre on them. So even if a lot of these isolates are expected to be commensal or contamination from the not significant growths, I think it'll still be interesting to check for resistance in these isolates. When I'm preparing the isolates for Sensititre, I'm hoping to prepare them for DNA extraction as well, so that I can perform genomic sequencing in the future, with the aim to confirm the identity of the isolates, particularly the non-significant growths, as I don't have any reports about their identities at this stage. So if IDEX considered them non-significant, they don't send them for further identification, and to look for antimicrobial resistance genes as well. I would like to thank my supervisors, James and Laura, the AMR group and the microbiology group for their support, Green Cross, UVet and IDEX for their cooperation, and Reset Market Werribee for their advice. Thanks for your attention.
Thanks, Amy. That was excellent. I'm sure there are questions. Ree had a question, but then you presciently answered it in the next slide on your talk.
I can come up with another one.
I knew what you were going to ask, Ree.
Great anticipation. I did want to ask another one. You might have covered it and I might have missed it, but are you aware of what cutoff values IDEX has been using to call those gram negatives, like the E. coli's, resistant to amoxicillin, or ampicillin? And are you happy with what the levels that they're using?
Yeah, they use CLSI standards. Yeah, but I don't know the numbers specifically.
Yeah.
I can look into that.
And Matt has a question straight after here. You want to just
is it right if I unmute?
Absolutely.
Yeah,
that'll be easier. Hi, Amy. That was a great talk. And I'm
Hi.
sorry I missed the first little bit of it because I was in another meeting. So you may have covered this, but I was interested if you're looking at pre and during study submission rates of how many cultures they're doing. Do you have a control group for where, say, the practice has been promoting you should do this, but it's not part of your study and there's no subsidy, so that you can compare, raising awareness versus actual subsidization of submissions and the impacts?
We don't have a control group. I provide the like the guides and all that, but we do not we don't really interfere with what they actually do. So we kind of just let them run wild. So in terms of previous numbers, this is what I've, so in the January to June last year, which is the 2012, which is directly comparable to the time period for this number. So this is the data I've got, but I definitely would like to look into how they treat urinary tract disease in the kind of year before this, the year before, the culture and sensitivity was free, and compare, whether or not antibiotic prescribing rates has changed with the availability of free culture and sensitivity. Does that answer the question?
Yeah, I guess because I was at the beginning, I just wasn't sure whether one of your questions was, is cost a factor in why people don't do this?
Yes.
And I thought for you to explore that, we'd probably need a group where the clinic just reminded people this is best practice, and perhaps choosing a different corporate group, non-Green Cross, so that you don't have overlap with what they're doing, where you just get them to send out some information to the vets about what is best practice for urinary treatment of urinary tract infections, and then see whether their data changes just with being reminded they should do it rather than being subsidized to do it.
I think, Nat, the part of the problem with that lies in the underlying data collection is done through Vet Compass.
Yeah.
So in some way, we do have a group of practices like Green Cross practices that aren't involved in the trial directly, and we've had lots of interactions with them around antimicrobial stewardship.
Oh, great!
And sort of what would be good practice and what is not good practice, and those sorts of discussions. So we do have that sort of control there, but a lot of the rate of submissions and stuff, that data is coming from Vet Compass, and so a lot of other practices aren't engaged as well with Vet Compass as Green Cross is. So.
Oh, that's great. I didn't realise it was only select Green Cross clinics that you were doing a subsidy with.
Just these 9.
Only 10. Yeah.
10.
Nine.
Yeah.
Sorry.
Yep.
Yeah.
That's
great.
it.
Thank you so much, Amy.
Thanks,
Good luck with it
Nana.
all.
Thank you.
Great study. I look forward to seeing what you find.
Thank you.
Anna's asked, have any of the vets you've spoken to had specific challenges that they've highlighted?
Most of the communication I've had with the vets were to do with complicated or recurrent urinary tract disease. So in terms of what do I do? We've had this dog that has had 3 infections in the last 2 months or so, and it's mainly to guide them towards not going straight for high importance antibiotics like enrofloxacin if other options were available, and to do further investigation, look for urinary tract abnormalities, things like that before, rather than putting it on multiple courses of antibiotics, and just doing that for the rest of the dog's lives. So that seems to be the cases where they do contact me so far.
Glenn, you've got your hand up there.
Yep. Thanks, Amy. That was a great talk. I guess the one thing I always wonder about when we do these sorts of analyses on sensitivity data is where so I think in the plates you've got your screening for imipenem resistance and pip-tas resistance and things like that. How do you handle those results? Because you don't want to send out data into the cyberspace that tells vets that they can treat every urinary tract infection if they just reach for imipenem or whatever. So how do you handle that data, do you think?
That's a good question. Yeah, I think again, if the urinary plates are good because they specifically have the plates that the drugs that are commonly used in practice, and you can easily find the ratings for and things like that. But yeah, I do agree that there might be too much information in the gram plates. I'm not quite sure how what the answer to that is, Glenn, but that's good food for thought.
I don't have I don't have an answer either, Amy. I'm not. I guess what I had in mind was a reviewer of a recent paper of Rees, who said, who complained that you didn't want to follow a rubric that only solved 95% of cases when there was one drug you could reach to that would solve 100%. And how you deal with somebody with that sort of attitude to responsible use of antimicrobials.
Yeah. I think we need to keep stressing using low importance antibiotics wherever possible, as much as possible, and only reaching for those high importance antibiotics, if we really have no other options.
I think as well, Glenn. Can you hear me, or Mike? I just got a thing saying my mic is not working.
I can hear you, James.
Oh, cool. Okay, no, I just had a message there. I think as well, Glenn, that part of it is, I mean, like with all research, we get to have a look at it first, so we get to see what the resistance patterns are like, and what proportion of them are resistant to those highly critically important antibiotics. There's no real need for us to report those back to the profession at large, but it does also help us when we're dealing with our colleagues in human health, if we're able to say that this proportion were resistant or susceptible to these antimicrobials that they're more interested in. So rather than informing our stewardship programs, I think it might inform our interactions with our human health colleagues.
Yeah, I'd agree.
Thanks, James.
Walter is flying the flag for socialised animal medicine, so that's great. I agree. Just out of interest, FYI, sort of, Walter, we had a conference a few years ago where Brendan Murphy, who was the Chief Health Officer, was critical of animal health for not doing more culture and susceptibility testing, and I said I agree. I thought it was a very important one health issue. He said yes it is. I said so we'll have your support then for putting it on Medicare, and I think his blood pressure dropped and he went very quiet and started. So I'm with you, Walter. That's right. From the looks of it.
Thanks, guys.
Does anyone else have any other questions for Amy? No?
I'll stop sharing.
In which case, if you could just join with me in thanking Amy for an excellent presentation, we'll let her off the hook.
Thanks, everybody. Thanks for coming on a random Monday.
Thanks, guys.
Thank you. And thanks, Aaron, for making sure everything's running smoothly.